right, let's start with chapter 16, care of the postoperative patient. So we've done pre, intra, and now we're at the postoperative time frame. Of course, safety is always one of the concepts that we're going to cover, especially anything to do with perioperative care. In the postoperative area, we're going to also look at gas exchange, comfort of the patient, and tissue integrity. All right, what does PACU stand for? That's Post Anesthesia Care Unit. And no matter where your patient goes, as soon as they come out of the surgery suite, that's when the postoperative period begins. There are surgical care improvement project measures that have been established, and that should say perioperative period, in the perioperative period, and they're reevaluated as you go along. So you have the preoperative period. This is the reason it was written this way. You have the preoperative period skip measures that you measured preoperatively, and now we're going to measure them postoperatively to see how they compare. So we've decided that post-anesthesia care unit is what PACU stands for. And your goal in PACU is to anticipate, prevent, and manage any complications that come up after surgery related to anesthesia, the surgery itself, and any comorbidities they may have. So the Joint Commission, as part of their safety movement, their National Patient Safety Goals, requires report be given between every level of care. From ED to the med-surg, you get report. From ICU to OR, you give report. From med-surg to ICU, you give report. This is true for the operating room to the PACU as well. As a PACU nurse, you should be given report from the circulating nurse that was in the OR with the patient and from the anesthesia provider, whether it was a CRNA or an anesthetist, the doctor, anesthetist. When you receive reports from anyone, you need to take the time to restate in your own words the information you are given. You should be asking any questions until a common understanding is established. Okay? The respiratory system. Of course, postoperatively, you want to make sure that you have a patent airway with adequate gas exchange. And in the postoperative period, patients remain at risk for pneumonia. So we want to make sure their airway is patent. Note artificial airway when it's applicable, the rate, the pattern, the depth of breathing, breath sounds, any accessory muscle use, any snoring or stridor, and of course any respiratory depression or hypoxemia. Okay, in the postoperative period, all patients remain at risk for pneumonia. Okay, they're also at risk for shock, cardiac arrest, respiratory arrest, clotting, VTEs, GI bleeding. Surgery is very, very stressful on the body. And we already talked about respiratory assessment post-op. Now let's cover cardiovascular. Okay, so cardiovascular, we need to look at those vital signs. You need to be listening to heart sounds, cardiac monitor, look at their rate and rhythm, peripheral vascular assessment. You're going to monitor for those VTEs. We're going to compare our vitals with those that they had pre-op. And we want to be sure and report any blood pressure changes of 15 to 20 points systolic or diastolic immediately. Okay? So you're going to watch for decreased blood pressure, like I just said. You're going to look at the pulse pressure, which is the difference between your systolic and diastolic pressure. All right, so it's just your systolic minus your diastolic pressure. And normal pulse pressure is between 30 and 50. A higher pulse pressure is often associated with increased risk of heart attack or stroke. All right. Decreased pulse pressure may indicate blood loss, congestive heart failure, or cardiogenic shock, or decreased blood flow because the ventricles aren't working right. Abnormal heart sounds. Heart sounds are like bank tellers counting money. After they've counted several thousand normal $20 bills, they're able to pick out a fake $20 bill really easily. So always listen to the heart tones, whether you think you're good at it or not. If they're abnormal, it could indicate a fluid volume deficit, cardiac depression, hemorrhage, or maybe just the effect of drugs. Bradycardia could indicate an anesthesia effect or hypothermia. Tachycardia could indicate hemorrhage, shock, or pain. Listen to heart tones while you feel the radial pulse. Are all the beats perfusing? So is there a difference between pulse and heart rate? Of course there is. When you're looking at the monitor and you're feeling their pulse, do you feel something with every beat that you see on the monitor? What you feel is the pulse. What you see on the monitor is the heart rate. So there can be a difference in those. So your patient will be on a cardiac monitor the whole time. As a PACU nurse, you'll need to know your rhythms, and we're going to go over and learn those when we get to critical care. VTE prophylaxis in the post-op period, we need to make sure that we get everything going, whether it's put on their TED hose or do SCDs, and we need to address those before we take them on to the floor or wherever they're going. On admit to your unit, if you're in a unit and you're receiving a patient from surgery and there are no orders for prophylaxis, this will need to be addressed immediately, okay? Anticoagulants, antiplatelets, SCDs, that's sequential compression devices, TED hose, elastic wraps, and early ambulation are all things that can help prevent VTEs, okay? Signs and symptoms to notice when assessing the legs are redness, pain, warmth, and swelling. If you see any of that, you need to let the doctor know immediately. They may be forming a clot, okay? Coag therapy should extend until the patient is up walking around. So if they're still in the bed for the majority of the day, yes, you need to keep those SCDs on. You need to keep their TED hose on with the prescribed amount of time that you take them off per day. For the neurologic assessment post-op, you're looking for their level of consciousness. Are they awake? What were they like before surgery? Are they back to their normal? You're going to observe them for lethargy, restlessness, and irritability. Test their coherence. Do they answer your questions appropriately? Do they follow directions when you tell them to take a deep breath? On the med-surg unit, post-operative patients' level of care should be assessed every 4 to 8 hours. Of course, you're going to be noticing every time you walk in the door to see the patient, which is going to be a lot more than every 4 to 8 hours. Okay? All motor functions, remember, are depressed with general anesthesia. So we're going to start assessing, are they moving their arms and legs? Can they lift their head up off the pillow? Motor and sensory after spinal and epidural need to be assessed as well. Assess the level of sensation lost by pricking the patient's skin with a needle. And what you're looking for is the area when the pin prick begins to feel sharp and not dull. Okay? Compare the strength of the limbs. Is the right hand stronger grip than the left hand? Can they move their legs? Can they move them equally? Is one weak? Are the pulses different in either? When you raise the head of their bed, does their blood pressure drop? If so, the sympathetic nervous system is compromised and they're not ready to leave the PACU yet, okay? And that can be caused by anesthesia. Let's talk fluid and electrolytes. Surgical patients are at high risk for fluid and electrolyte imbalances. Why? Think about it. It's partially because of their NPO status before surgery, fluids that are lost during surgery, which would include blood and other body fluids, and Also, the fluid and electrolytes especially can be influenced by how much fluid was given in surgery. Okay, so maybe they had to give a lot of fluids to try to keep the patient's blood pressure up. The electrolyte readings that you get soon after that, if you drew blood and checked their electrolytes, may be diluted. So it may show that they have a lower, say, sodium than they actually do when you get their fluid balance right. So because of those things, you could have a fluid volume deficit. They could be dry or a fluid volume overload. Of course, the older population have more problems with fluid and electrolyte imbalances after surgery. You're going to keep a close eye on their hydration status in the PACU and Med-Surg, and you'll assess for this by what? How are we going to assess their hydration status? We're going to inspect the color and moisture of the mucous membranes. We're going to check their skin turgor. Where are we going to do this on the elderly? On their forehead or on their chest? Is their skin dry? Does it tint? You're going to look at all of these things. We're going to look at the amount of drainage on dressings. So I don't know if you're aware of this, but our physicians at Minden, when I worked there, really wanted us to keep up closely with our fluid loss. So we would weigh our dressings dry before we put them on, note that weight, and then when we took those dressings off, we would weigh them again. And if you will weigh in grams, you can know exactly how much fluid is in that dressing, because 1 gram equals 1 milliliter of fluid. So you can do the same with diapers for output. 1 gram equals 1 milliliter of fluid. So having accurate INOs in the post-op period is very important. You want to measure everything in. That's IV fluids, if you have to lavage their NG tube, if you put water to dissolve meds in and you put it in the NG tube, any oral intake, everything, every single thing, and compare it to their output. Your output should include catheter or urine output, drains, NG tubes, and dressing drainage. Your acid-base balance is affected by respirations, metabolic changes during surgery, loss of acids or bases in the drainage. For example, an NG tube drainage and vomiting rids the body of acids, which causes a potassium deficit and causes metabolic alkalosis. So those are all things that you need to keep a really close eye on. So the urinary system postoperatively. Watch for urinary retention. Anesthesia, physical manipulation of the bladder and ureters can cause urinary retention. We're going to inspect, palpate, and percuss our lower abdomen for assessment. They may need a short-term catheter. You'll just have to kind of assess as you go along. If they have a catheter, assess the amount, the clarity, and color of the urine. If they don't have a catheter, you should be measuring urine with a hat or some other type of urometer, or weighing the diapers or the pads. You're going to report a urine output of less than 30 milliliters an hour pretty quickly. Post-op assessment of the GI tract. Nausea and vomiting is super common post-receiving anesthesia. So what are the dangers of nausea and vomiting in a post-operative patient? What about dehiscence or evisceration? You don't want to pop those stitches that we just put in. They're fresh, and that's a definite danger with nausea and vomiting. You can also have electrolyte imbalance like we just talked about. It causes, when you vomit, it increases the intracranial pressures and increases intraocular pressures. So any surgeries that are on the brain or on the eyes definitely need to be careful about controlling that nausea and vomiting. 3 types of patients are more likely to have nausea and vomiting. These are the obese patient, those prone to motion sickness, and anybody that's having an abdominal surgery. So You can do some preventative measures like maybe Zofran or Dramamine or scopolamine. Antihistamines and anticholinergics can help you not be sick, but they may also cause urinary retention, so that's something to keep in mind. Intestinal peristalsis return may be delayed in people requiring long anesthesia. Or it can even be delayed if you have to handle that bowel a lot during surgery. And of course, opioids also decreases peristalsis. It may be 24 hours or better until gut peristalsis returns, and it may be even several days for those with major abdominal surgeries. So, of course, one of the key assessments for post-operative patients is, bowel sounds. How long must you listen over one quadrant before charting that a patient has no bowel sounds? 5 minutes. You need to listen a total of 5 minutes before you can chart that there are no bowel sounds. When assessing bowel sounds, make sure you inspect and auscultate before you palpate or percuss, because these two maneuvers may temporarily affect peristalsis, and you may think that they have started back with some peristalsis, and it's actually just because you manipulated their gut some. Constipation can be a problem after surgery, so get them moving quickly, and as soon as they are able to eat, encourage increased dietary fiber, and they may have to have a gentle laxative or even an enema a time or two to get them going, or maybe just a Dulcolax suppository. NG tube drainage. A lot of times, with abdominal surgeries especially, they insert an NG tube during surgery. And it's to decompress and drain the stomach, and it also kind of promotes GI rest. So it suctions out any of those natural juices that the GI tract is making. And if they've had surgery, it gives time for the GI tract to heal. Sometimes we'll use it to provide short-term enteral feeding through it. It's really good to monitor any gastric bleeding and to prevent any intestinal obstruction. So you're going to assess drained material from that NG tube every 8 hours. And don't forget that having an NG tube to suction, usually low intermediate suction is what you'll have after surgery, can cause fluid volume deficit, low potassium, low sodium, and metabolic alkalosis. So you can think of it just like you would vomiting, because it's removing stomach content. So make sure and record it in the I&Os. Wound healing. The outer layer of skin will heal in about 2 weeks, bar any trouble. That's just the outer layer. Complete healing or complete tissue integrity may take 6 months to 2 years for it to heal all the way through, depending on the wound, where it is, and the health of the patient. Always wait on the surgeon to remove that first dressing. You're going to assess the incision at a minimum every 8 hours. And what are we looking for there? We're going to look for redness, increased warmth, swelling, tenderness, increased pain. The drainage from the wound should be sanguinous at first or bloody looking, but it should begin to change to serosanguinous and looks more like diluted blood, pinkish, and finally to serous or yellow. If serosanguinous drainage continues after the 5th day of surgery or is increased instead of decreasing, this is a sign of possible dehiscence. So what is dehiscence? It's another word for wound separation, okay? So what's the difference in dehiscence and evisceration? Evisceration is the total separation of all the layers and the internal organs protrude, and this is a surgical emergency. These most often happen the 5th to the 10th day after surgery. That's weird, isn't it? You would think it wouldn't happen, but people get to moving around more because the outer layer has just about healed up and they overdo it. It happens more often to obese patients, diabetics, malnourished patients, and those with immune deficiencies. So they'll feel some kind of pop when they cough or vomit. So what do? Let's look at a chart It's chart 16.6 on page 283, and you need to know these steps to do in case of a dehiscence. All right, you're going to contact that surgeon immediately. Going to call a rapid response. And just remember, if a patient has eviscerated, you're not going to leave their side because you do not want them to get up out of that bed. Their guts will spill into the floor. I know that sounds disgusting, but it is a great, great possibility. So you're going to call a rapid response to get more people there. Provide reassurance and support the patient. They'll be very anxious. You're going to have them remain in bed. Use a sterile technique and unfold a sterile towel to create a sterile field. Open up an irrigation set and place the basin and syringe on the sterile field. You're going to open up several abdominal dressings and place them on the sterile field. Put on some sterile gloves, and we're going to saturate those dressings with this sterile saline. Warm saline is best. Place those moistened dressings over the exposed viscera, okay, or the guts that are protruding. Then place a sterile waterproof drape over the dressing to prevent the sheets from getting wet. Okay, if saline's not immediately available, cover that wound with gauze and moisten it with sterile saline when you get it available. But you should be getting some people there to help you so they can run and get you what you need. Don't attempt to reinsert those protruding organs. It may be tempting. Looks like maybe you could push them right back in there. Don't do it. I'm telling you, you will injure the patient and the surgeon's going to have a stroke. Assess for manifestations of shock and document the vital signs. Place the patient in a supine position with the hips and knees bent. Raise the head of the bed 15 to 20 degrees. So really, it's not totally supine. They're going to be laying on their back, but it's a really low Fowler's position. Continue to assess the patient and get their vital signs about every 5 to 10 minutes until that surgeon gets there. And keep those dressings moist. Don't dare let the dressings become dry. When the surgeon arrives, make sure you tell him everything that you did, and then of course you're going to document the incident like you normally would. And if necessary, prepare for emergency surgery. So let's say that maybe they just have one small IV. You might want to start another IV. And go ahead and make them NPO right away again, just in case they have to go to surgery. All right, so this is a good picture to show the difference between dehiscence and evisceration. See, in the dehiscence, you still have that membranous covering there that the wound has opened up, but the membrane is still covering and keeping the guts on the inside. All right, let's look at these. At the top, you're going to see a Penrose drain, A. That's a Penrose drain. And then another type of drain is a JP drain, and that's B. JP stands for Jackson Pratt drain. All right, this is just some more. This is kind of a stay. You see how these have the big stays there in the middle, kind of to help that gut stay. That wound stay closed there. All right. So what are the two major assessments postoperatively? First, we're going to assess for bleeding, and then we're going to assess for pain. So we talked at length about pain assessment. So you've got to make sure you talk with your stoic patients about healing and how keeping the pain under control facilitates healing. Look for signs and symptoms of pain and anxiety, which will be restlessness, increased pulse, blood pressure, respirations, crying, and encourage your patient to express when they are in pain. Just because a patient is nonverbal doesn't mean they don't need pain meds. We've talked about that at length already. You may need to use that behavioral pain scale, with the numeric and the FACES, that's the FACES revised pain scale, to assess their pain. So we want them, this is a behavioral pain scale. We want them comfortable and relaxed, but not gorked, okay? There are some things to take into consideration when evaluating pain. Do they have an increased pulse and blood pressure? They may be in pain. Are their respirations increased? Are they sweating profusely? Are they restless? And in older adults, they may be confused. Are they wincing, moaning, or crying? All of these might indicate, they can be psychosocial indicators of pain. We've talked a little about labs. Post-op labs are very important. Are they having electrolyte imbalances? Are they getting an infection of some kind? If so, where? Do we need to culture the area of suspected infection? Are their kidneys shutting down? Are the NSAIDs like ketorolac, which is Toradol, causing kidney injury that we're giving them post-op? And of course, follow any labs directly related to the surgery or any pre-existing condition. What is hypoxemia? It's a low oxygen level in the blood. It's most common on day 2. Why do you think it's most common on day 2? Could have an infection starting in the lungs. Maybe it's an accumulation of medication. So what can we do to prevent it? We want to monitor that airway. We want to monitor our SpO2 or our pulse ox. Put the patient in semi-Fowler's position. We want to do oxygen therapy if they need it, breathing exercises for sure, and get them up and moving as soon as possible. So it's not unusual for post-op patients to need a little O2 for the first 12 to 24 hours. Consider, if they're having trouble with keeping their pulse ox up, consider over-sedation from medication. So what kind would that be? Usually opioids and benzos, okay? So what do we give to reverse opioids? Narcan or naloxone. That's the same medication. Naloxone, I believe, is the generic name for it. But then we have to do something else for pain, right? Once we reverse that opioid, we've got to do something else for pain. What do we give to reverse the PAM or LAM meds, or the benzos, like Ativan, which is lorazepam, or Versed, which is midazolam? We give romazicon. That's for reversal of the benzos. And the generic name of that is flumazenil. So if they're having trouble keeping their pulse ox up, immediately raise the patient's head of the bed. Consider immediate oxygen, encourage deep breathing, and cough. We need to be turning and moving every 2 hours. Our incentive spirometer, we need to be doing every 1 hour while awake. They should be splinting and coughing and up ambulating as soon as possible. We want to give some pain meds 30 to 45 minutes before their scheduled activity, like getting up to the chair or PT, and it will help them move a little better. So, interpreting. They have a potential for compromised gas exchange. They have a potential for infection and delayed healing and acute pain, and they also have a potential for decreased peristalsis, which can cause nausea and vomiting and constipation, as well as a postoperative ileus. We just covered this, so I'll let you read it on your own. How we can improve gas exchange. Preventing wound infections. Some physicians believe that air drying promotes healing, but remember, a draining wound is always covered with a dressing. Use aseptic technique to change the dressing, always, always. After the initial change, you should be changing the dressing at least once a shift following the unit's or physician's policy. I had one doctor that only wanted us to use alcohol prep pads to clean the wound. Some may want it irrigated with saline. I mean, it just depends. Staple or sutures are usually removed 5 to 10 days after surgery, and some physicians will then place steri strips with directions to leave those steri strips on until they fall off on their own. Clean the wound before removing staples. Why? So as to not introduce infection into the staple site. Okay? What is the purpose of drains? Is to provide an exit route for air, blood, and bile to prevent deep infection or formation of an abscess. This is a Penrose drain. We saw one earlier on that lady's neck. These should be covered with a dressing because there's nothing to catch the drainage out of the end of this drain. 2 to 3 inches of the drain should show. It will be gently pulled out and cut back to 2 to 3 inches as you go. Sometimes they will put a safety pin near the exit site to keep the drain from pulling back into the wound. In this picture, they used a stitch on either end of the drain. These are JP drains, or Jackson Pratt drains. See how the bulb is deflated? It's squeezed in. This creates suction. The tube that runs from the body to this bulb should be stripped at least twice a day. So that means you will hold the tube firmly near the skin and you will pull your fingers down and strip it into the bulb. The bulb shouldn't be emptied until it's half full or every 8 hours at a minimum, and output should be noted on the I&O as well as the color and any smells that it might have. Whenever you're having your patient ambulate, you want to pin these to the gown and keep them from pulling. It looks like that top bulb there is secured to his chest wrap. What might happen to that bottom JP drain if it's not secured before he gets up? It's stitched in, so it probably won't come out, but it will cause a lot of discomfort to the patient and irritation at the insertion site, and it could come out. We've talked about pain management, but don't be afraid to integrate complementary therapies like positioning, massage, relaxation, diversion techniques. Again, here are a few interventions to promote peristalsis. You want to do a really accurate abdominal assessment. Make sure they're drinking plenty of fluids. You're going to promote mobility, help them get up and get around. Try non-opioid interventions. You can do some gum chewing to get the peristalsis going and some hard candy. Now remember, with the hard candy, you want to avoid any red because we don't want anything coming out of there that's red that might be mistaken for bleeding. You can also do some pharmacological managements if needed. Care coordination is part of your job. It's no different for post-op care, okay? Same for post-op care as anything else. All right, after this, you're going to have some questions to answer on the next slide. And then you also have an open book quiz that needs to be done in Brightspace, okay? So make sure that you don't forget to do that open book quiz in Brightspace.